All right. Welcome to Dear Healthcare Provider, the podcast where patients, providers, and policymakers meet to have purposeful conversations about health and the issues that impact access to care and health outcomes. And today, have the privilege of having one of the biggest members of Team Michele right here in the studio is Dr. Jeffrey Antimarino.
Well, I appreciate it. I'm really happy to be here, and thank you for the invite.
Oh my gosh, thank you so much for taking time out of your busy schedule because I know you were super busy, with surgery, with seeing your patients and kids and wife and all of those things. So
it's packed.
Yes. So the privilege is truly mine. So I want to give our listeners just a little bit of your background, all right, so they know who you really are in the world, besides being on Team Michele. Dr. Antimarino is a certified American Board of Plastic Surgery surgeon. He is also a member of the American Board of Aesthetic Plastic Surgery. He's a fellow of the American College of Surgeons and Allergan Medical Aesthetics Consultant and a speaker for Cartessa Aesthetics. Dr. Antimarino graduated from Pepperdine University in Malibu, California, with a degree in biology and received his medical degree from Creighton University in Omaha, Nebraska. Dr. Antimarino went on to train in general surgery and plastic surgery at one of the premier surgical training programs in the country, the University of Southern California. During his general surgery training at USC, he had a well-developed bariatric surgery center, which allowed Dr. Antimarino to train in the latest weight loss procedures. It gave him the insight needed to better understand the problems patients may face when dealing with obesity and their journey in maintaining weight loss. His plastic surgery training was extensive in breast reconstruction, reconstruction after weight loss, burns, pediatrics, birth defects, and cosmetic procedures. Dr. Antimarino excelled at USC and received numerous honors and awards during his training, many of them in teaching. And we could go on, but I won't because he has quite an extensive background, and I can attest to the blessing of this man's gifted hands. And I'm open about the fact that I've had plastic surgery and some things we'll probably be touching up in the future, right? But anyway, I think that it's important for you to be on the show to talk to our listeners about what plastic surgery is, what it isn't, what they should be aware of, what they should be looking for in a physician, what they should be doing in order to prepare for these procedures and all that. So we're going to get into that. But before we get into that, I ask all of my guests one question. What brings you joy and makes you smile?
I think right off the top of my head, I'm at a point in my life where my kids are now college and just beyond. So I think the thing that gives me the most joy right now is watching them excel at what they want to do, and they've chosen their path. So it's neat to be a part of that and to watch them as young adults. And so now you can kind of take pride in what they're doing and be interested in what they're doing. So that's probably gives me the most joy. And spending time now is pretty much a empty nest with my wife again. And lastly, honestly, it's my work. I mean, I really enjoy seeing my patients. There's no place like the operating room. I mean, it really is just the greatest place on earth.
One of the things I will say about you, now we've known each other, I think going on about 5 or 6 years now, right? And one of the things I say about you is that, and you have a pretty tight schedule. Really, but the way you see him here, I have never walked into his office and that has not been the energy that you bring. And I so appreciate that as a patient. You're always smiling, you're always kind, always ready to listen. And I know for me as a patient, that means everything. So keep doing what you're doing.
Well, I appreciate it. I mean, honestly, I feel blessed to be doing what I do. And so it's what I've always wanted to do. And by the grace of God, I've been blessed to do it. So every day is joyful.
I love that. I love that. All right. Well, now we're going to get into the meat of the conversation.
Good.
Okay.
Yeah, let's bring it on.
All right. So, I want to spend some time talking about plastic surgery. And, we've actually been on your lives talking about this in the past, but I really want you to walk us through the most common types of plastic surgery procedures that people seek after weight loss.
So when patients go through a weight loss journey, and it doesn't matter how they lose the weight. So, it can be surgical, it can be diet and exercise, it could be with medication. So there's lots of ways to do it. But I think the biggest thing that, patients need to understand is no matter how you do it, those are not cures. None of them are cures. And so that's the one thing I try to impress upon patients is that, these are all tools. Everything that we do is a tool to help keep the weight off. But I think that's the biggest thing is the education that no matter what you've done to lose weight, you still have to work at it. There's nobody.
Wait, Doc, I'm going to stop you. Say that part again.
Yeah.
I want you to say that again.
Yeah, it's there. You still have to work at it just because, and I used to lecture to a lot of weight loss groups, and especially after bariatric surgery. For years now, and the first thing I tell them is, I don't know a single human adult that doesn't have to think about what they put in their mouth. And some patients have more food cravings and have other issues, but we all have to worry about it. And as we get older and our bodies change, especially for women because of the hormonal changes, nobody gets a free pass. Nobody can go eat pizza and ice cream and without consequences. And so you always have to work at it, and you always have to remember that no matter what you're doing to keep the weight off, it's just you constantly have to work at it. So I think the biggest thing when patients lose weight, the two things that you have to consider, there is excess skin, but there's still pockets of fat that may not have come off in the manner in which you liked it. And so I think some patients come in and they're sort of confused by it. And early on, when I was a resident at USC, and when we were really starting to do the gastric bypasses early on, this is like late 90s, we didn't really know a lot about it. And so patients were surprised by the excess skin that they had.
Yeah.
And we couldn't really warn them about it because we didn't really know to the extent. And so, and it all depends on how much you lose, what age you are when you lose it. I mean, I've had patients in their 20s lose 100 pounds and it looks like they've lost 30. And I have patients in my age group, older age group, that have lost 45, 50 pounds and it looks like they've lost 100.
Wow.
So plus the genetics takes a large part of that. So anyway, so when patients come in, we have to address those areas. And so a lot of times they'll come in and it's a lot of excess skin, bellies, arms, legs, face, but they also have pockets of fat that didn't come off as much because we all have some areas on our body that are sort of genetically predisposed to keep fat. For men, it's mostly love handles. For women, it might be arms or what we lovingly call the saddlebags, the sides of the legs. And so you might lose 50, 60, 100 pounds, but those areas still have sort of too much. It didn't contour, and there's really no rhyme or reason. So they may be in to address just those pockets, and so we need to contour those, or they're coming in because they have excess skin, and we need to pare that away and shape everything down again.
So, Dr. A, talk to us about, because folks are in the gym, and I'll tell you on my journey, I was doing that too. And you're in the gym and you're trying to spot different areas, and you want certain arm shape, you want certain leg shape, and you're doing all these things, and it doesn't happen.
Right.
Talk to us about that, because I think that our listeners are out there trying to figure this out,
Right.
and some of the conversations that you and I've had, I'm not sure that the spot thing works.
Right. And there's no way that you can spot train. And, a lot of patients will go to the gym and they want to lose some fat or some weight around the middle. So they're doing thousands of crunches and core exercises, and they find that it's really not happening. And so you can't really do that. And I hope that, you know, the trainers that are out there would tell patients that. So it's a whole thing. And I read something a long time ago, and when I was younger, I didn't really believe it. It's, you know, you can't outwork a bad diet.
Yeah.
And so, you know, when you're younger, you can go to the gym and, you know, especially for guys, you know, you could eat a pizza and a bucket of ice cream, go to the gym, and you're still losing weight. But as you get older, that's not the case. The diet is the most important part of it.
Yep.
And the exercising is an adjunct to that. But you really have to be careful of what you're eating, how much you're eating. So portion size is really key. But when you go to the gym, you just have to, and I think this is the hard part, we have to accept our body the way it is, and that's just how we're built. So one of the things that we, you know, that you had asked me about, so when patients come in, one of the things I have to try to get them to understand is this is your body habitus. And for things that we don't maybe like and we don't like, everybody has things that they like about themselves, you know, in their body, and some things that we don't. You know, I know people that, you know, we'd all like to be a little taller, would all like to be a little more muscular, and some people have and some people don't. So a lot of times patients will come in and say, I want to do some liposuction and a tummy tuck or whatever because I want to see a 6-pack or an 8-pack. I say, well, just because you go to the gym and exercise and you lose a lot of weight doesn't mean you're going to have a 6-pack. You know, people that have it, that's their body habitus. But I don't want you killing yourself trying to attain a body that you can't attain. So again, you sort of have to, as you go through this and as you've gone through this, you start to understand how you're built. We can maximize, and as a plastic surgeon, we help patients sort of maximize what their body habitus is. So when patients come in with photos of what they want to look like and things like that, I look at them with them. Sometimes they're on, you know, they're pretty close to what they're looking at. And other times I use it as an education to say, yes, but that's really not how you're built. You know, this person you're showing me might be, you know, 5'10" and just very lean build, and you might be 5'3" and a little curvier. So we have to try to help patients understand, or anybody to understand that, you know, this is who we are. And so we can maximize who we are, but you can't go and just spot, you know,
so
exercise.
What you mean you can't make me look like Beyonce? Like you can't do that?
Right. But well, for the same
Doc.
reason, I can't look like, you know, Brad Pitt either, you know, so.
That's not what those gifted hands do, right?
Exactly. So I think that's the thing. And so sometimes that can be a hard lesson for a patient, but it's hard for all of us. And at some point you just have to say, you know what, this is just what, you know, I'm dealt with. This is what the good Lord gave me. And so, but how do I maximize me? How do I make me feel good about me? And that's the key.
See, that is the key.
Right.
I'm so glad you're saying that out loud, is like, how do I maximize me? Because I think that, well, one, when you struggle with obesity, there's a lot of head stuff that's going on in your head, right? And so trying to reconcile just what you think about yourself, what you see in the mirror, all of that. But then I think that we're fed a lot of messages, right, that tell us we should look like Beyonce. We should look like, you know, Joe Scott. We should look, whoever it is that has the body that we want. We're fed those messages when the reality is, like you said, we just need to, one, love ourselves and maximize what it is that we have. And that's harder. That's easier said than done, right?
Yeah, I think in some cases, but you know, it's kind of weird that there's all this stuff that's out there, and that of what we're supposed to, or what the, you know, the best nose is, the best, you know, body habitus, the best height, you know, and some of these things there's just no way you can. It's just not us, right? So. But I think we're inundated with that, and women more than men, since early on. And, you know, women are more prone to be looking at magazines and things online and about, you know, who is popular, why they're popular. And I think that it's hard because, again, that's going through your mind. This is the way I should look. And my question has always been, who sets that norm? Who is in charge of that? Because from early, I mean, this goes back to way before we were born. Who depicts? And so it was interesting is a number of years ago, my wife Ella and I got to do a lecture together. We've never done that before. And it was called Beauty Through the Ages. And we talked about that on two different levels. Beauty through the ages as far as time eras. So 1930s, 40s, 50s, 60s, and what was popular for body habitus and looks. But we also did it as time through the ages of our own age. People in their 30s, people in their 40s, people in their 50s, people in their 60s. So it was really a lot of fun to write and do together. And through all of this, you know, remember back in the 70s, it was very thin, very, you know, almost emaciated models, and this is what they were looking for. And then in the 80s, it became more natural, more the girl next door. And then the 90s started kind of changing a little bit, and then it became very muscular. And so it's changing. But and the question I always had is, who says that's the best? How did that come about, and why do we all believe it?
Right. That's the bigger question. Why do we all believe it?
Right. It's a mass acceptance to, and somehow somebody or a group of people is saying this is what's popular now.
That's right.
And I think the hard part is, you know, we all love social media and everything else, but I think there's a lot of bad information out there.
Absolutely.
And you know, kind of swaying people into this mass hypnosis that, okay, you know what, everybody needs to look like the Kardashians, and those are fads. And so when patients come to me and they want this this gap between their thighs, and they want this side stuff, and I always tell them I don't do fad surgeries, because in about 3 or 4 years that's not going to be okay, and then you're going to want to change it. And it's not like changing your clothing where you just go and buy new clothes. Now you've altered your body. Now we're dealing with scar tissue and scars and things. So I don't do that. I just think that, again, you have to help the patient. What's best for you? And I've said to many patients, you know, we're talking about surgery today, but I got to think about you in 10 years, 20 years, 30 years. And if I'm going to do something today that in 20 years is a problem for you that can't be fixed, why would you do that today? And you have to help people think through that, because we're all young and we all think, you know, hell, you know, I'm always going to look like this. And then you get to be a little older and you're like, what happened? You know,
Exactly.
Time marches on.
Yeah.
So I think the surgeons and the doctors have to be aware of that. And I think that's the problem I have with a lot of plastic surgery. And what I mean by plastic surgery with air quotes is there's a lot of cosmetic stuff done by not just plastic surgeons, but a lot of physicians that I don't think take into consideration for the patient. And so we have to be able to, as the so-called experts in it, to say, you know what, I don't think that's in your best interest. And it's okay that the patient walks away and goes somewhere else. Or hopefully they listen to you and say, you know what, they're probably right. Maybe I shouldn't do that. You know, and so that's, I think we as a group of physicians have to come together and say, you know what, the stuff that's out there may not be the best for these patients of ours, and we have to be almost I don't want to say a parent, but we need to be somebody that they can confide
have
in.
Integrity. How about that?
Yeah. And say, you know what, I understand, I see it on there. You know, Ella keeps me updated with all this stuff on social media, what's out there, so that I can be, you know, look at it and say, you know, I think that's just a little far-fetched and a little bit out there, so to try to rein people in.
Well, I want to highlight a couple things you said, because you dropped a lot of nuggets there. And one thing that you said, I don't do fad surgeries. That's powerful, because you and I both know that there's a lot of plastic surgeons out there, and they're all about fad surgery, okay, because they make a lot of money, right? And so I think that it's important for people to hear that from somebody who has such a stellar reputation as you do, and that if you're looking for a plastic surgeon and the first thing out of their mouths is they're selling you all these procedures, or they're even quick to co-sign on what you came to the office saying that you wanted them to do, it's like, that's not the best fit. because you can find yourself into some actually really dangerous situations from a health standpoint, right?
Right.
And so I think that it's really for you to say that, and from somebody who, I mean, I certainly respect, and I always laugh, and you and I laugh about when I first came to your office, and I was like, hey, let's do a mommy makeover, and I had this whole list of things that I wanted done, and you were like, whoa. It's like, let's talk about your history. Let's talk about, you know, where you've been and what's going on. And you really did a nice job, and you always do a nice job of telling your patients what to expect, and to help to kind of mitigate those unrealistic expectations, because I really do think that if you follow and look at some of the things that we're seeing on social media, you think that you come in, you get a BBL, and tomorrow you're on the beach and you're looking great. And that's not how that works.
Right.
You know? And so, and I think also, and I'd like for you to kind of speak to this as well, it's not all done in one clip all the time, or is it in your best interest to do it in one clip?
Right. So a lot of patients will come in, and especially weight loss patients, and you know, they're so proud, they've lost the weight, they feel good, and that's really, again, what I used to tell the groups I would lecture to. This is all about wellness and your health. It's not just about making you look better. This is about you feeling better and taking, you know, the weight off orthopedically with your joints, you know, medically and physiologically, getting your blood sugar under control, your blood pressure under control, just all of these things that losing weight helps you.
Improving your metabolic health,
Correct.
right? All those things you just listed.
But again, you can be too thin. We all think the more weight you lose, the better you are. And that's to a point. There's always a, you know, sort of a balance in everything we do in life. And so, so when we talk about, you know, patients say, what's my ideal body weight? Well, who knows what that is? Nobody. And if a doctor tells you your ideal body weight is X, they're guessing, because there's no way you can punch that in. You can say on average, people that are, you know, men that are 5'10" are 175 pounds, but that's not everybody. So, you know, I think that you have to just help people get through that and, you know, understand what's best for them, and walking them through that journey. But they come in and they're excited and they want to do a lot of stuff, because now they see these issues and they're tucking stuff into the pants. And sometimes they'll come in and say, I'm still wearing the same clothes, but I've lost 80 pounds. And so you have to say, look, what I usually do is say, okay, so let's talk about the areas that bother you. And I write them down. And I say, okay, now I want you to rank them from the things that bother you the most to the things that bother you a little. And then let's rank them in order from most concerning to least concerning. And then at that point, you can say, okay, personally, I like to do surgeries between 4 and 4.5 hours max, because you can start having some issues, healing and infection, more prone to infection after 5 and 6 hours and stuff. But really, I try to keep them in that 4 to 4.5 hour mark, because I want the patients to recover quickly and get back to their lifestyle. You got to get back to work. You got to get back to your exercise. You got to get back to your family. So what can I do in 4 to 4.5 hours? And so, and there are certain body parts that you can match up. You can do breasts and belly, which is one of the most common. You can do arms and breasts. You can do legs and belly, legs and arms. I don't do legs and bellies together because the incisions are too close. But, and then you say, okay, you know what, if we're going to tackle this, we can do this at once. And sometimes it's just, you know, I don't like my breasts, I don't like my arms. Well, a lot of times we can do that in one surgery. But if it's multiple, I'll say, look, we're going to take 2 to 3 stages to get you done. So you're looking at probably 1.5 years of time, because we want to give you some time in between surgeries too. And I know there are colleagues that will do a surgery and then in a month or 6 weeks do another one. But realistically, physiologically, the body hasn't recovered completely yet. So for me, the earliest I would think about going back to surgery is at least 4 months. And most of the time I put them off for at least 6 months, because I want the patient to be completely back to all of their exercising routine, their family stuff, everything that we talked about, back to work, no issues, not even thinking about the surgery they had. Their body and their mind is back to normal. then to hit them again with another surgery. And it's not so much anesthesia, because that wears off in about 24 hours. It's the physiology of healing. And some of the incisions, as you know, are very long. And so, and there's a lot of undermining and things that patients are not going to know. It's, you know, if somebody comes in and I'm going to say, hey, can you paint my house? And he goes, yeah, it's going to be 2 days. I'm like, why can't you do it in an hour? Well, that's just physically impossible. You know what I mean? So that's where, as the surgeon, you have to say, look, this is what's best for you, and I'm not going to do all of that. There are some people that would do 10 to 12 hours of surgery and get it all done at once. But when I see those patients that come back to me, a lot of times they need touch-ups, and they've had problems healing, and then instead of getting back to work in, you know, a week or so, they're off of work 6-7 weeks because they physically can't do it. They're exhausted, you know. And I think, so how have you helped that person? I get it. We're all, I mean, I'm one of them. I want it done yesterday, but realistically, what's best for you? If I can do parts of it and get you back, and then so each surgery is a little surgery compared to one major undertaking. You're back to your lifestyle quickly, and then you never worry about it. It's in your rearview mirror.
Yeah, and I think the healing, I mean, I don't know what your healing rates, I would think they're pretty high, but I feel like when you do it that way and you honor the fact that the body needs time to heal, I think that you get a better outcome. I think that you feel better about it, and it does give you time. Because even after these surgeries, you still have to wrap your brain around what you look like versus what you thought you were going to look like, right?
Yeah, because it takes time. You don't, as you said before, you know, you get a BBL and you're out on the beach the next day. Every surgery takes time to heal, and it's going to look rough at first. It's not going to look pretty yet. And so there are actual physiologic stages of healing. And you have to go through all of them. And so most of the time it takes 6 to 8 months for you're pretty close to your final result. But in those first few weeks to even a couple of months, and I always have to keep reminding patients, I know you want it done yesterday, you want to look great, but your body has to go through the healing process. The scars you have to scar, and then you have to heal that, and then those scars have to fade, and the tissue has to soften, the shape has to improve. And that all goes through that, but it's time. And, you know, patients will come in and say, you know, my son or my daughter's getting married in 2 weeks. Can you do a facelift? I could, but you're going to miss the wedding, you know, and, you know, and I think but again, we as a plastic surgery community have sort of put it out there in a way that, you know, you should be able to go do all of this. I know there was one surgeon that we used to tell patients, you know, you do a breast augmentation, you should be out having dinner with your friends that night. Like, why would you tell anybody that?
Yeah, right.
Because the majority of people can't do that. And I wouldn't want you, even if you felt good enough, to do that, because you're going to get exhausted. And why would you want to be out after anesthesia? You have swelling and everything. Why would you advertise that? Why would you propagate that misinformation? And so patients will come in and say, well, I had a friend who heard this or heard that. I'm like, you know, you have to really, again, bring everybody back to the reality that no matter what, this is real surgery. Even though it's aesthetic or cosmetic surgery, it's real surgery. You have incisions, you have scarring. Just like if you had your gallbladder out or a gastric bypass or a sleeve, it's real surgery.
It's real surgery. I agree. And I can attest to that. I've had several of them, and it's true. And I think, so the little before and after pictures that they see, you know, on Instagram and TikTok, wherever you're at, you know, they think the before and after was they had it last week and this
is
week.
Them today.
And this is them today. And that's not how it works. And so I think it's important. And I think you also brought up some other good points around the history of how we're duped into thinking about what we should look like. And I could say this as a Black woman, right? I'm not shaped like Barbie, and I'm never gonna be, right? That's not what but I think, to your point, is that we've got to really challenge some of this hypnosis, as you say, that we are lured into thinking, well, we're supposed to look like that. And it's like, well, who said that? It's like, you are you, and you have the body that you have. And plastic surgeons are not here to, like, engineer
Hmm.
these perfect bodies,
Right.
but to help you to develop the perfect body for you.
Right.
And that's a very different mindset, right?
Right.
And so I think that that's why I respect you so much, and I tell all my friends to go to you and all of that, because I know that you're not going to just tell people or just do whatever people are saying
Right.
that they want done if you know it's not in their best interest.
Right. And I think for me, it's the psychological impact that plastic surgery has that can be very powerful. And so, my goal has always been to help people feel better about themselves. And we're
Hmm.
human. And so, we do feel better when we look better or
Hmm.
we look the way we want to look. And
Hmm.
again, it's the way we want to look for us. And and there's lots of studies that show when people are happy with themselves, they're very happy to be, it's good to be around them. They're very
Hmm.
warm, they're very open, they're very giving. And, but when people are not happy with themselves, it's tougher to be
Hmm.
around them. So, so I feel like if you can get through with somebody's expectations and you can meet their needs and get them the result that is good for them, those patients feel better about themselves. And that's what it should be. It shouldn't be, when you come in and patients will come in and say, what can you do for me? And I'm like, I don't play that game.
Hmm.
What's bothering you? Because
Hmm.
I can do many things, but that may not be the best thing for you, that you want. Might see
Hmm.
something that I can say I can fix and you think, well, I'm okay with that.
Yeah.
But I also don't want you to go home and go, oh my gosh, he thinks that my arms need to be done. And now because he's
Right.
the expert, we're experts in surgery. We're not experts in what your body's supposed to look like. Only you
Mm.
are. You come to us
Mm.
and say, in my mind, this is the way I want to look. Can you get me there? And so, as you know, when I talk to patients, I always say, how can I help you?
Mhm.
What is it that you see? And let me see if I see it.
Mhm.
And let me see if it's possible.
Mhm.
And then if it is, these are where the incisions and the scars are going to be. And I've had some patients say, ooh, I'm not ready for those scars. And I say, that's
Mhm.
fine.
Mhm.
Better now than after
Yes.
surgery. And also, that's good. You're not ready for it.
Mhm.
And the question is, especially with aging, patients say,
Mhm.
am I ready for a facelift? And I say, I don't know. Only you can answer that question.
I love that what you just said. You said you are experts in surgery. You're not experts in individuals and
Right.
your body and what it is for you. And
Right.
that is powerful.
Mm-hmm.
That is very, very powerful. So you talked a little bit about, we're going to shift gears in a minute
Mm-hmm.
because I wanted to talk about the newest venture that you took on a few
Mm-hmm.
months ago. But I want to ask you about what would you say to patients in terms of the nutrition?
Mm-hmm.
Because you talked about that, and we know that obesity is a disease. You and I have had many conversations
Mm-hmm.
about that. So I don't want anybody listening to think that you're saying, yeah, just exercise more, because you're
Mm-hmm.
saying quite the
Right.
opposite. But what you are saying is that there are things that we have to be mindful of, all of us, right?
Mm-hmm.
And in my advocacy, I'm always telling people, listen, I've had weight loss surgery, I've had all the things, I have all the things, but it still has not given me a pass to just do
Mm-hmm.
whatever I want
Right.
to maintain, right? So, what things would you tell patients, first of all? What are the things preparing for surgery
Mm-hmm.
and the after surgery?
Mm-hmm.
Three things that you think.
Number one, looking at their social history. So the main thing is smoking. Main thing.
Mm.
I mean, above and beyond almost anything else. It's nicotine and the carbon monoxide from smoking. So we tell patients at least a month before and at least a month after, no smoking, no vaping. Vaping is showing that's even
Yeah,
worse,
they're finding that it's worse.
and I know people don't want to hear that,
Mm-hmm.
but even nicotine patches, nicotine gum, they're all constricting blood vessels, and patients, again, think they're going to get away with it, and sometimes they do, and sometimes it can be a disaster in healing. So that's number one. The other
And
thing
so I'm going to
is,
stop you for 1 second
yeah,
about because somebody may not know what that means. the reason that it's important for your blood vessels not be constricted is why?
So you're not getting the blood supply to the healing tissue. And so when you do that, now those tissues that need more blood flow don't get it, and so you don't heal well. And so you can actually have open wounds, and it takes time to heal. And everybody thinks we don't want it because it's bad for your lungs and your heart and things. Yes.
Well, that's true too. But
in my case as a surgeon, you need to be oxygenating. And so when it constricts all those little blood vessels, same thing is, and again, this is something that people aren't going to want to hear. If you're smoking marijuana, I don't even care if it's medical marijuana, it's still marijuana, and it affects your lungs. It affects how you oxygenate. It affects the blood vessels. So we tell them the same thing. I get it, why you're being prescribed it, but it's still
a whole nother
an
show.
issue. So that's number one. Number two is looking at their medical history. So a lot of times patients are young and healthy, and they can come in, or older and healthy, not a problem. But if they have a history of insulin-dependent diabetes or heart issues or have had a stroke, then we need to, again, as surgeons, work with their primary care or their neurologist or whatever. And there's times where I will call that physician and say, we're planning this. What do you think? What are the precautions? Do you think it's a good idea? And we have to work together. Again, as a medical community, we have to work together for each individual patient, not as a mass, but each one. And there's times where I've had their surgeons say, I don't, or their family physicians say, you know what, I don't think that's going to be a good idea for them now, but maybe in 6 months, let me optimize them. Let me try to do some things. Perfect. Because again, the surgeries that we do in plastic surgery should be pretty quick and easy to get through and then get through the healing time. So you want to optimize everybody. So that's key. And if you're not really following that person's medical history, then you're going to get caught, and ultimately the patient's going to get caught. So those are the two first things. And then lastly, and so the last one is nutrition. We want to make sure what their diet is like. Are they taking in enough? And I'm not talking about, only eating vegetables and only eating this or that. It's whatever, as we get back to that ideal body weight, you just say, look, where are you in your normal daily activity, your normal eating habits, and your normal exercise habits? What are the demands on you? And when you can be in a certain weight comfortably, where you're not killing yourself, you're not trying to get to the gym 6 hours a day, then that's sort of at that stage of your life, that's your ideal body weight, right? And so, and it changes as you get up in age or something happens in your life, and life comes at you sideways most of the time. So that's going to change. So, but what I want to do is make sure that if it's a more involved surgery, they're getting enough protein in their diet. Those are key. And so sometimes, especially with my gastric bypass patients, because of the nature of that surgery, and the plastic surgeon or cosmetic surgeon needs to understand that. You've rerouted your intestines. You made the stomach extremely small. So you're not eating a lot. You're not absorbing a lot because your small intestine has been shortened to a very small segment. And so again, that's where most of the nutrients are being absorbed. So when you shorten that, and you're not taking in a whole lot, you don't have a lot of absorption time. So protein is one of the things that you don't absorb well after gastric bypass. So I treat those patients by saying, look, you need to be on protein shakes or protein supplements, because you can't eat enough chicken and beef and, take in eggs and all that stuff, because you don't have the capacity to put that in through your stomach. So you need to do some shakes, and I don't care which ones you use, but you need probably 50 or 60 grams more protein 2 to 4 weeks prior, and for certainly 4 weeks afterwards. We want to pump that up. And there's some blood tests that you can do to kind of check on what your protein intake has been. So those are key things of, making sure that you have enough nutrition right before, and certainly in the next 4 to 6 weeks afterwards, to give your body what it needs, because your body will find it somewhere. And a lot of times with gastric bypass patients, they break down their own muscle mass. So those patients are slower to heal, and they feel more tired because your body's looking for protein, and so it breaks down the muscle to get the protein it needs to heal those incisions. So if you give it the protein, they won't look to their own body to break it down.
I love that. So really the social habits, you need to look at your social habits. You need to consider your medical history, right? And you absolutely need to be paying attention to your nutrition, getting in that protein. And that's the recipe for a better outcome, right? And that's great. And I did want to ask you this. Where does BMI play a role?
Yeah, and we've talked about this a lot. I think,
have.
again, the problem with things like BMI, weight, fat content, I think these are all parameters that you have to look at the whole picture.
Yes.
And you can't say you can't look at one parameter. In this case, you know, you asked about BMI. You can't look at somebody's BMI and say, well, your BMI is too high. Now, you can say from a healthy standpoint or from a risk standpoint, higher BMIs, and we all agree to that. Higher BMIs mean you're a little bit higher risk. From an anesthetic standpoint, same thing. And so I think there has to be an idea of what that healthy number is. But I think if you're going to look at somebody's overall well-being and look at a single number, weight, you know, you can have somebody, I mean, look at athletes. You know, some of these athletes are, you know, we were talking before about hockey players and basketball players. So these guys are 6'4", 6'5", 250 pounds. And by their BMI, they're obese and there's not an ounce of fat on them. And they're in great shape because they're running or skating or, you know, everything every day. I mean, you can't look at that and say, okay, well, your BMI is indicative. What you have to do is use that in context to everything else. And so, and in medicine, that's the way it is. Everybody has a little bit of different homeostatic or balance point. And so when I was training, you know, going through general surgery, and we were doing a lot of critical care and taking care of patients in the ICU, you had to get to know the patient overall and looking at all the numbers from head to toe, you know, and what those all mean for that patient. So I think, you know, they want cutoffs, and the insurance companies use them like crazy, and hospitals have them for a reason. But I think that's when you have to be able to talk about that, either doctor to doctor or doctor to patient, is saying, look, you know, for these reasons, you know, you have to lose some weight. Or I talk to them and say, you know what, you know, the patient otherwise is pretty healthy, and, you know, how do we optimize them for surgery? But again, I think, just like we talked about before, we have this thing now where everybody's looking at weight and BMI. And you should be, you know, for men, and all of the questions in medical school, it was always, you know, a 5'10", 170-pound man was always, you know, the norm. Yeah. And it was like, I don't know too many 5'10", 170-pound men in the United States. So I don't know, we're sure where they're getting this information from. But that's not always normal. I think I was in college and I was a competitive swimmer, and I was 6 feet, 175 to 180. You know, I wasn't that guy. I mean, even then 170 was really thin, you know, for me. And so even then I'm thinking, you know, where are they getting these numbers? So for people that are listening, you know, BMI is a good marker, but it doesn't tell the story. You're looking at one instance in time, but you're not seeing the motion picture. And that's the important thing, is what's the overall? How is this patient? Do we have problems? You know, you have marathon people that are out there and they have cardiac disease, and they're the thinnest, supposedly fittest people out there, and yet they have problems that more genetics. So again, you have to take in a lot of this stuff. What's that person's genetics? And that's why we can't all look like somebody on the magazine cover, because we all have different genetics and different nationalities, and you know, you just can't fit somebody into that. So BMI, be careful. It's a good rule of thumb.
It's just a reference point.
Correct.
That's it. And it was never meant to be a medical tool.
Again, it was a reference point in a whole series of data that you collect. You can't pick out one and go, well, that's the whole story. It would be like reading a book, picking one page in the middle of the book and saying, well, I know what this book is about. You know,
Right.
you know nothing. You know
nothing.
a single piece of information, but you have to dig deeper than that. You have to look further.
Right.
And again, as we talked about optimizing somebody for surgery, there are patients in, BMIs of 38 or 39 that are in pretty good shape. And I have people in BMIs of 24 that are not healthy. Their nutrition is terrible, but that's how their body habitus is.
Well, I think that, and I'll use myself because, my stuff is out there. But for someone like me, some plastic surgeons would have said, oh, yeah, your BMI is too high. Like, we're not going to do the surgery. You really could care less. You were like, let's talk about your history. Let's see what's going on. What is it that you need to have done? And it's not that you didn't ask those medical questions. You certainly made sure that my metabolic health was where it needed to be.
Right.
And I think that's what people need to hear. And I think other healthcare providers, it's valuable to hear that perspective from you.
Right. And there's different facilities that you can use. I mean, I do the majority of my surgery in an outpatient facility. And so sometimes we have to have a little bit stricter criteria because you're not in a hospital. You're nearby, but you're not in a hospital. So they should be stricter. And I think the surgeons need to understand that as well, because there's times where patients will come in and anesthesia will look at the patient and say, this isn't a good patient for us. Outpatient, but it might be better for an inpatient, or even as an outpatient in a hospital setting. And so even patients with a little bit larger BMIs, as long as they're optimized and you're doing it for in a reason of take off weight, because a lot of times patients will lose weight, and I've had several patients, mostly men, that have gone from 500 pounds down to like even 300 pounds, and they have all this excess skin, and now they can't exercise because that skin and that extra weight is now hanging down to where they're plateauing because they can't exercise. So going in and taking off that tissue, called a paniculectomy, I would do that in hospital settings, even as an outpatient. But in case they needed something, all of the adjunct people are there to help. But again, now, and I've had several men where they've gone from 500 down to 300. We did a paniculectomy. Now they're down to 200. So they've lost 300 pounds, but they wouldn't have gotten there had we not intervened and helped them from a surgical standpoint so that they can continue to do what they need to do to keep the weight off.
There it is. Exactly. Well, thank you for providing that. So I'm going to shift gears because, you and I could talk all day. We won't, but we could talk all day. But I want to talk about the fact that earlier this year, you launched a new weight loss program that incorporates GLP-1 medications into your program. Explain how the medications work and why they're effective for weight loss, and why you felt that this would be a vital service for you to offer through your practice.
So the GLP-1, so people know them as semaglutides, and on the market, Ozempic and Wegovy, and they're good drugs. They've been around for a while, so that's another thing. People think they're new drugs.
They're not.
They've been around treating type 2 or non-insulin dependent diabetics for more than a decade with good outcomes. And so what they were finding, though, is that those patients that were helping to control their blood sugar, and that's what they are. So a GLP is, it's a medication. It's a glucagon-like peptide that we have in our bodies, and the whole role of that is to, when you eat something, your body releases that targets the pancreas where the insulin is made, and it actually helps you make more insulin. And people that have diabetes that still make their insulin, sometimes they don't make enough, or their body's kind of resistant to it for some reason.
Insulin resistance, right? Because lots of us have it.
Yep.
Yes.
And so what they find is these medications help lower the blood sugar, which is always a good thing. And what they were finding is there's also some weight loss involved. And in those type of patients, the weight loss actually helps control the blood sugar. So it's a positive thing. And so nobody really knows why people lose weight with it. But the effect is that patients that are on it, what they really find is that it slows down your stomach emptying, which is a good. It can be good and bad, so it has to be monitored. So what that means is that you're not emptying your stomach as rapidly, so you feel full. So patients on these medications don't have the hunger and the cravings that you normally would, and so you don't ever really feel hungry. So you eat less, and the food cravings have seemed to have gone away. And so patients that have, crave salt or sweets, and so the food cravings seem to go away. And so there is a lot of studies being done right now why that is. They've studied, and they know that the medication doesn't cross into the brain. This blood-brain barrier. It doesn't cross, at least the studies that they're looking at now, it doesn't show it. So how is that working? So patients are eating less, those high-calorie foods. They're actually not even, they don't even have the desire for them as much. They're also finding that in Europe, they're looking at using it that people that have alcohol cravings,
yes,
they have less cravings.
Yes.
So it's helping with people with alcohol
They've been saying the
addictions.
gambling, because the same centers in the brain that are
Right.
activated.
These mu receptors in the brain that, and so that's how it works, sort of what people will feel. So they're not as hungry. They don't eat as much. Now, on the other hand, so they're not eating as much. So they're losing weight, but they're not taking in protein either. Protein is huge, and now you have to start making sure you're drinking enough, water and things like that. You stay away from sodas and high calorie, juices and things like that. So water is always good, or electrolyte waters, things like that. And you got to start taking in more protein. So that's why it is. And the reason we got into it is that, again, as a service, we didn't get into it because we thought, okay, this is going to be a new niche and we're going to bring in a lot of revenue. It really wasn't part of our conversation. But we were finding a lot of patients that were coming to see us for surgery were on them. And when I would ask them, okay, who's giving this to you? Who's monitoring you? A lot of times they were like, well, I'm getting it through this, and they're not really being monitored. And so,
have you heard some people are getting them at the beauty shop and the barber shop?
Yeah,
and like, wow.
I think that's a little crazy. I don't think that's happening.
It's a little crazy, right? Yeah.
But it needed to be regular. So what we thought was, look, for the patients that we have, I wanted people to do it and do it, being monitored and do it safely, because it does work, and those medications are very effective. But again, we have a goal in mind, and a lot of times I'll ask patients that are on it from other, sources, and I say, so what's your goal? Well, I'll be on it forever. I'm like, well, I'm not sure that that's okay either. So, again, that just means that for every surgery, for every medication, for every time that you see your doctor, there has to be a diagnosis and a goal. What's the end point? Do you need to be on this medication forever, like blood thinners, or are you going to be on it for 6 months and you come off, or, so I think these medications, again, should be used as a tool, like we talked about at the beginning, not as a cure for all of this stuff. And so I think for certain people, I think you can get them off of it in a certain amount of time. Some patients will still continue to have issues, and that might be something that you have to think about. But so we started it not to drive patients into surgery, not to drive up our revenue, and we have it tapped at we only have maybe 30 patients at a time, until we. And then it's closed. We don't have any room until somebody cycles out, and then we can open it up for new patients. So for us, it's not everybody can come in and be treated, because that's not how it can work.
So you mean we can't get the Groupon and come see you?
Right.
That's a thing, right?
And in our program, it's my oversight, and Angie, our nurse practitioner, she's doing the weekly thing. And so patients are coming in weekly, and we get lab tests on them after before, after the first month, and then at every 3 months. But we've had patients where we sent them to their primary care because of what we've looked at, their past medical history and their lab results before we started. Those patients needed to go see a doctor, for certain reasons.
Now say that. No, I want to stop because, this is all the rage, and there are all kind of folks popping up with various clinics, and you can get the GLP-1s. But you said something I think you should highlight is the fact that you require that people have a medical workup before you start giving these things. And if you find that they're not in a place that this should be the thing, you send them back to their primary care, right?
Right.
And that's because why?
Because you want to take care of patients. You can't forget that your job is to take care of people, and it's not a revenue source primarily. It's a revenue source secondarily. You have to take care of the patient. And so, and I think that's where the medicine has to be a little more collaborative. And there are a lot of places where, it's being run without oversight. And I have patients, and I'll say, where are you getting this? Well, I'm getting it from a place across the states. And I said, well, who's your doctor? Well, I did a Zoom call with somebody. And I was like, okay, but did they examine you? Did they say, no, they do some blood work and they tell me it's fine. And then they send me a script. And I said, okay. These patients of ours have to physically come in. They see Angie. I go through all the blood work with everybody, with Angie. We talk about who's doing well, when they're cycling in, cycling out, and, they're weighed, they're measured, they're photographed. So, again, what I said before, it's a positive thing. I want patients to feel good about themselves. And somehow, as you said before, when you can't control your weight, there's a lot of things going on in your head. Then you feel bad, and you feel like, you're not doing enough, or you're not good enough. And that's wrong. You should feel good about yourself. So this is something that I can help somebody feel better about themselves and feel like they're in control. And as adults, we always want to be in control of everything we do. And if food is a problem that you can't control, then maybe we can help you control it. And so, we actually have Leslie Bonsi, who is world-renowned dietitian.
She's amazing.
Everybody has to talk to her, and we encourage people to stay with her. And she's not a dietitian that says, eat broccoli, eat fruit. She works with you. What do you like to eat? And she's amazing.
She is amazing.
And we've had such positive feedback. But that's part of our program. And we have somebody on board that is worked with Kansas City Chiefs, the Steelers, Penguins, from athletes down to everyday people. We all have the same issues. I don't care if you're a professional athlete or me and you. We still have the same food cravings. We still have the same habits that are bad that we've learned, a comfort food when we're not feeling good, So she helps you with that. So all of that, I think you have to take into consideration, because again, you're helping patients feel better about themselves. And that's the key thing. But if it's a revenue source constantly, you're going to overlook some of these things. And it's really important to get somebody back. And Angie has not only training, but extensive experience with mental health. So, and she's the one,
and that's a
really
big
in
piece.
charge. Again, because why are you craving these things? Why are you, what's the source? And sometimes, and we have therapists on staff, not in our staff, but that on,
that you
on
can
the
refer
program,
to, yes.
that we can refer, because sometimes people, again, need to see them either as well or instead of. You got to get control of that, and then we can do it. You can't cure everything. And the studies are showing, obesity, and we've talked about it, is multifactorial. It's not just because you're overeating. There's a lot of things, and genetics plays a big part of it.
And it's not your fault.
Right.
It's not your fault, but you can, it's the 360 approach, right? It's like you still have to have the tools in the toolbox. And that's what I know you and I both are aligned in, that is that no matter what path you choose or what path you need, whether it's surgery, whether it's medication, whether it's all of the things, you have to be willing to understand and embrace the fact that it may take multiple things, and it has to be a comprehensive approach. Mind, body, spirit, as I say. You've got to be dealing with that. And it's not one and done. Right. It's not one and done. It's ongoing. Because I've been on this journey for a really long time. And all those things you just mentioned, I have in my toolbox. All of them, because I think that from a physiological standpoint, I definitely know the difference now. I didn't before, between the food noise, and I think the medication does help to shut that down, right? Those cravings. But I can also tell you in transparency that there are certain things that are triggers, and I can definitely now say, well, I'm not really hungry, but I really do want that chocolate chip cookie. So what's that about? That's about something else.
Right.
That's not about the physical hunger.
Right.
That's about something else.
Correct. And I think that's, as adults, that's what we're really dealing with. And so for a long time, it was so funny because Ella, my wife, would say, she'd hear me, snacking at night. And that was my big thing. And she'd say, are you hungry or are you bored?
I still struggle with that.
Right. And so, and we all do. And so that's the biggest culprit. And so you have to get to the source of that in your own mind. And sometimes we can do it on our own. Sometimes we need help getting there or help pointing it out, because you may not even know you're doing it.
That's right.
And so a lot of this is just who you are, but it's also your upbringing, is how you've been educated without knowing it. We all react to things, but if and that's why some of the therapists can help you work backwards to say, you know what, we all want, we don't feel well. We always talk about comfort foods, a bucket of, whatever,
Whatever it is, right?
mint chocolate chip
right.
ice cream, or a chocolate chip cookie, or for me, Oreos, And it's like, if you can help identify, sometimes you just say, you know what, I'm going to do something else, and I'm not going to do that. And
that's where the mental health comes in.
Correct.
Right?
And so again, I don't want patients to feel bad. It's the same thing as we talked about diabetes. Some people just have it, and it's not, you still have to treat it, and you might be upset that you have it, but it's just your reality. And so you might need to be on 2 different medications. Somebody else may not can eat, whatever they want, and they don't have diabetes, but they have other issues that you don't have. So
That's right.
we get so tunneled into thinking we project what we don't like about us on everybody else. Well, how come they don't have this problem and I do? Doesn't matter.
It doesn't matter.
You do. So take care of it so that you can optimize it and forget about what everybody else is doing. Put your blinders on and what is it that I'm going to do to maximize my body so that I feel good, and then I can be the best version of me.
That's right.
Doesn't matter what I do and what I can eat is not the same thing as you. And I might look at something and I'm like, geez, I wish I could eat that.
Right.
I can't eat things after 9 o'clock because I get heartburn, but my son can eat
whatever
till he goes, he can eat at midnight and sleep the night. I'm like,
that's right.
It's just different. It's just not me.
It goes back to what we were talking about earlier about accepting your reality and embracing that, and not feeling shame or blame, but it's just how you're set up. And so you honor that, right? And do whatever you need to do. Now I'm going to ask you a question about, because there's all this stuff I know in this, particularly in the medical side of this, in terms of GLP-1s and the commercial brands versus compounding. Some doctors are concerned about, how the compounding medications are being made, and the FDA doesn't have as stringent rules on compounds. But I'd like for you to talk to us about, how did you come to the place that you felt comfortable enough, you didn't feel like your license was on the line, to offer these options for people?
So, and that was part of the thing that we wanted to really get into before we launched it. So it took us, I'm going to say, probably 6 months of research before we actually got this up and running. Because it wasn't, it was all of the bits and pieces. Who was going to be a part of it? How were we going to do this? Who did we trust? And so I talked to a lot of colleagues of mine that were already doing it and got the names of certain ones. And there were a couple of pharmacies that kept popping up through all of them. And then you can do the research. So I think that, people have to remember that compounding pharmacies has been around forever. And because back in the day, it used to be physicians mixing their own drugs way, way, way back, and with pharmacists. And so pharmacists would diagnose and add things. So compound pharmacies aren't bad, but you have to do your research on them. And they should be, so even though the FDA isn't as strict, they still oversee them. But so the FDA really looks at the big pharmaceutical companies from a federal guideline, and the states really rule the compounding pharmacies. So there are strict guidelines of what the states are looking for. So they can't just go and make up whatever they want. That doesn't happen. And, because they are accountable and they are subject to law
the same
enforcement and everything.
Yeah, all that.
And so, and the FDA does have a faction. So a lot of that, like these, there are components of the FDA that actually does oversee these in a sort of a broader sense. So the FDA can come in and inspect.
Got it.
There it is. And the feds can do whatever they want.
Okay.
But I think that they should be like that. But again, this is more state driven. But I think that when you look at, again, total transparency, you can go on their websites and you can see what products they use. You should have, and we get where they're coming from, what compounds are actually being mixed. You get that affidavit. And so if you're not getting that, then I'd be more suspect. We have it that this pharmacy only sends it to my office. It's office-based only. And then as the physician, I can do with it what I want. And there are some times where patients are, getting it through online stuff. And I think that's the problem. So you always have to think about, yes, there should be oversight at every level. There should be oversight at the pharmaceutical level, the compounding pharmacy level. There should be oversight at the physician level. There should be, at the patient level. Because again, when patients are, there's sometimes where patients are just given the stuff, they have to draw it up. So there's error there. Patients don't understand that. And well, I'm losing, 10 pounds in a month, but I really want to do 15. So if patients have access to the medication, they're dosing themselves. And if you're not being watched, and we don't do that, we draw it up, we inject them. Or we, if they're going to go away, for patients that we know can do it. Otherwise, we say, you miss a week, and then you come back and we'll dose you again, So we have that much strict oversight with these patients. And we talk to them, and Angie spends a lot of time with everyone. That's why we cap it, because she only has a certain amount of time, because she has other responsibilities in the office. She's not just doing this. We didn't make this, a complete separate section. It's part of ours. So she only does, essentially 1 day a week.
Gotcha.
A morning and an afternoon session twice a week, because she has so many other responsibilities. But we wanted those patients not to slip through cracks. So we said we capped it at a certain number. And I think that's what I would expect. And so when patients are just getting it, I think that you really have to think, I want patients to be part of a program anywhere where they actually have an MD or a DO overseeing a PA and a nurse practitioner. And a lot of times that's not happening because they're good medications, but just like every other medication, you can say insulin's a great drug. Atenolol is great for hypertension and cardiovascular, but if you're not taking it right,
that's right, it can
or you're
kill
not
you.
prescribing it right,
absolutely,
then it's problematic. And so I think sometimes we in the United States, we jump on things because it's on social media. Oh my gosh, this is all bad. It's bad when it's not regulated. It's bad when there's no oversight. And I think that's the key. If patients aren't, doing their homework, it's your body. Do your homework. Look at the who's prescribing it for you. If you don't know that person, you have, and you're just, you're getting it, people just want to lose weight. It's great. They hear all these great things. But again, it's always a double-edged sword. So I just recommend, go to your primary care, have them recommend something if they're not doing it. It should be, I really feel strongly about, there should be an MD, a DO, a physician overseeing that actually has hands-on looking at those patients. And if there's an issue, we need to know about it. And we've done very well that way, and patients have done very well, but it's very strict. And they have to really go through. Patients will say, well, I just want to, I'll just send the information. You got to come in. You have to sit with us. You have to go through a consultation, questions and answers. We got to go through this. And I'm not somebody who diagnoses things over the phone. If you call me, say, hey, I'm having this. All right.
Absolutely.
I'll see you today. I'll see you tomorrow.
Exactly.
But let's take care of it. Same with these patients. I honestly believe in my heart that's the way patients are going to get the best outcomes, the safest outcomes, because there's too much where it's out there that it's just wonderful.
There's a lot of microwave treatment out there, right?
Yeah,
There's a lot of microwave treatment.
It's really it's not safe that way.
So what would you say for somebody who's thinking about, because there's all the things going on around access. I call it pharmaceutical Hunger Games. I'm fortunate to be able to get the medication. Some people are not, and some people are saying that participating in a program like yours is a good alternative, and it increases access, right?
Correct.
So so from that standpoint, though, if I'm looking for something, my patient, and I don't really know, what would be 3 like red flags that you would say to patients? Listen, if this is going on, or if this is not in play, you need to run the other way.
I think that if you can get it, if you're doing a Zoom call with somebody on the other line, and sometimes a phone call, and you're not being physically examined, that's for
a red
me,
flag.
that's a major red flag.
Okay.
If you are talking to somebody across state lines and they're going to send the medication directly to you, that's a problem for me, because again, you don't know how to do that. You don't know how to draw it up, sterilely and inject it. You have to be taught that. You also have to know the outdates on things. You have to look for these labels. And so that's what our job is, right? And so I think if they can just say, you know what, it's this so much a month, and we'll just send it to you, that's a big red flag in my book, because it may work for you, but for some people, you can get into trouble that way. So I think those are 2 main ones for me. And the other one is, I think you can find out from the physician, where is this coming from? Let me look at this. Let me look it up online. Let me take a look and see what this pharmacy is all about, because they should have what their history is, how long they've been in practice, who they use. The one we use has been in practice many, many years, and they have PhDs, they have engineers, they have physicians, they have pharmacists, all working together. So it's a solid run group, and people get it from other countries, and patients are getting it. Well, I can get it cheaper in Mexico. When I practiced in LA, everybody was getting all of their medication, not just this, but medication from Mexico. There's no FDA down there. You don't even know what you're getting. It's coming from, they can say, and if you're, ordering it, because there's stuff that, we always joke about Amazon stuff. There are certain things that you can buy through these companies, but you don't know, are those really, there's a thing a few years ago with Botox, bad Botox, but they were getting it from people that it wasn't coming through the company that makes it. So you don't know that. So you have to be able to do your homework. And if you look up that pharmacy and you're not finding much information, that is the 3rd major red flag. Where is this? How long have they been in business? How long have they been in practice? What products are they using? And talk to your physician. Say, look, because sometimes they can compound different vitamins with it, or you may not need that vitamin. You may not need that supplement. And actually, depending upon your medical history, it may not be good for you. So again, that's why you have to have the physician saying, for you and your medical history, this is a better drug for you, and this is what we're going to do to order it. And that's the nice thing about compounding pharmacies. You can change it a little bit so you can actually change the recipe a little bit as the physician. You can talk to the pharmacist and say, well, for this patient, I want to do this. And that's okay. And that's the way it used to be years ago, before the big pharmaceutical companies. And the nice thing about them is they can mass produce it so that more people have access to it. So they're both good.
Except for that dollar price.
Yeah. But they're both good on one hand, but they can both be abused on another. And so again, that's where I still think you have to have regulation.
Yeah. So, I think what you're really saying is, like, listen, do your due diligence. Look for these things. If somebody is just meeting you and not like really doing their due diligence on your behalf, getting your labs, all of those kind of things, if they're mailing it and like there's no checks and balances, you need to be
more careful.
More careful.
It's your body. And we all want things, we can always justify in our minds. Well, I'll scrape the money from here and I'll go buy this, because we want things. We're human, right?
We're human.
But if you're doing that for your medical care, well, it looks pretty good and it'd probably be okay. If you have that, if there's a little inkling there, you probably just keep looking.
Yeah.
And
Yeah.
it's hard. I mean, listen, I'm not trying to be a hypocrite here and say, oh, just do it,
Yeah.
But you have to do your due diligence, and that's the onus of the patient to find that person that can, or that practice that can take care of you the best.
And so as we start to, because we've been talking for a long time, and I'm going to, we've gone over, but this has been so good. We've got so much stuff here, and I appreciate everything. And I think our listeners will benefit from everything that you've shared. But I think now from a healthcare provider standpoint, what would you tell other healthcare providers?
I would just remind them that, again, you're in this to take care of patients, and you really just have to do your best in doing that. And just to remind you that, the reason you have a job is because people need you. People have illnesses, and people are sick, or people have a problem that you are trained to help. And so you should always keep them at the forefront, that they should always be it's always in their best interest, not your best interest.
Truly patients first, right? Yeah. And all that other stuff comes after.
Always comes after.
Always comes after. Is there anything we haven't talked about that you think we need to leave with our listeners?
Hopefully, I think that just some good warnings. I think that hopefully this has been educational, and that people can take away, that done in the right way, things can be done safely, and you can get to your goals with a team effort, and work closely with, and the patient's part of the team. And so it's not just come in, wave a magic wand and you walk out never to be seen again, and you're wonderful. It's an ongoing process, and we all have to take that journey. But the medical team is there to help you, and I just hope that people, take that onus on themselves as well.
Yeah, that's good stuff. I did have one question I didn't ask you that
Sure.
I wanted to just see what your perspective was. Do you see a difference in terms of how your African American patients see plastic surgery and the receptiveness, or just any preconceived notions that you think come to the table?
I have a fair amount of African American patients for my whole career, but I don't see much difference in how they come in. I think they again most people, no matter what their race or ethnicity and things, I think most of them come in with some pretty good, expectations, but I don't see anything really different in that population. And I hope that, I think the way we have our practice set up, hopefully they feel like they can come in just like everybody else and tell me what's bothering them. But I think, again, you just have to look at medical history, because you have a higher rate of blood pressure issues and heart issues and maybe some kidney issues that are in that population versus another population. So, but I haven't, as far as expectations stuff, no, I think everybody, at the end of the day, it doesn't matter what color we are, we're all human underneath, and we all have the same desires and the wants and needs, and so, so I think that's a good thing, I think the shell doesn't really matter too much.
That's good. Yeah, I think sometimes in our beauty shop and barbershop conversations, it's variable in terms of, oh, well, that's like a privileged thing to do or what have you. And I don't know if people, but I would imagine that by the time people get to you, that they've done some research and are receptive to some transformational kind of services, right? Because that's what you do.
Yeah, and I hope, it's why we don't charge for a consultation fee. We don't, it's free. So patients can come in and just talk about things and be educated, and that's what we want. And so we want patients to feel, so there's no obligation. But if you're thinking about it and you think, well, I've been thinking about this a long time and I just don't know enough about it. And if you're looking at Facebook and Instagram and TikTok as your educational things, I would tell you just get rid of all of that stuff, but, find somebody, just go in and talk to them. But you shouldn't feel obligated as a patient. If you go into any plastic surgery office, you shouldn't feel obligated that at the end of the day you have to sign up for surgery. You just don't have to. It's just, you know, it's like if you're going to go in and look at cars, you know, you can find out what the costs are, what it does and things, but you know, no obligation to buy one. You know, shop around, do whatever you think is good for you. It should be an educational process, and so that's that's the way we want patients to feel.
Absolutely. Well, I think we have covered a lot of ground here,
Okay.
and I appreciate that. And listen, if you all are in the Pittsburgh area, if you're not, Dr. Antimarino is the bomb. And so
I appreciate that.
He will educate you. He will give it to you straight. He will not pressure you into, you know, getting services. In fact, he's told me many a times, yeah, no, we're not doing that. So, no, girl, we're not doing that.
Yeah.
So anyway, but I appreciate that. And I think that it's important for people to know, you know, the main nugget that you talked about is that you are the master of your own body and your own choices, and that's your job. Your job is to be the master of being a good healthcare provider.
Correct.
The master of surgery and giving it to people honest and straight, right? So I think that with that, we will say until next time. And thank you so much for being
here. I appreciate it. Thank you so much. It's always good to sit and chit chat with you. We could do it all day long.
We really could. We really could. So until next time, to my listeners, I wish you joy. I wish you peace and good health. That's it.
Thank you.
Yes.
That was
thank
awesome.
You.